Okay, today we're going to talk about scoliosis, a little bit about it, what you can do if you think you've got it, and the type of treatments that might be right for you. I'm going to start off with the definition. Scoliosis is defined as a three-dimensional spinal deformity involving a lateral or sideways curvature of the spine, which is greater than 10 degrees and includes an abnormal vertebral rotation. So that's what they mean when they say three-dimensional curvature, is that it's not only a slight curve to the side, that there has to be some form of rotation. In terms of the causes, the vast majority of scoliosis is of an unknown cause. It's termed idiopathic, and that accounts for about 80% of scoliosis, though there is some recent research to suggest that it has a genetic link. We also have congenital scoliosis, which accounts for about 10% of cases, and this is where the bony abnormalities of the spine are present at the time of birth, such as a wedged vertebrae. So if we looked from behind, we would see that the vertebrae is shaped almost like a piece of cheese, it's wedged, and then we get a growing of the joints away from that, bones away from that point in a curved pattern. You can also have other bony abnormalities like a hemivertebrae, so a slightly smaller bit of bone that's not quite a normal formed vertebrae in the spine. And then there are some other cases due to neurological disorder of the central nervous system or muscles, and they account for about 5 to 7%. So we rarely see that kind of client in clinic. There is also, and probably the more common that we see, is when a scoliosis develops after skeletal maturity in the adult, and that is called a degenerative de novo scoliosis, or a new onset. De novo means new onset scoliosis, so it's come about in later life. In terms of the prevalence of scoliosis, 0.3 to 0.5% of children have it, which is pretty low. Above the age of 18, the percentage increases to 2 to 4%. It rises further to 9% in over 40-year-olds, and this one always amazes me. It's more than 30% of those over 60. So actually, almost 1/3 of people over 60 will have some degree of curvature in the spine. There are a few other spinal deformities that are worth mentioning, mostly the frontal plane deformities. So we've got the sideways curve of scoliosis, and then we sometimes see that we find a forward curvature in the spine. These include postural round back, which is essentially totally correctable when we ask the patient to stand tall or to lay down, and gravity is no longer forcing them into that position. So that's really an issue with the soft tissues, the way that they're holding you. Structurally, that's fully reversible. And we see that a lot. The other is a true structural wedging of the spine, called a Sherman's kyphosis, or Sherman's disease kyphosis. This is where instead of the sideways curvature of the spine, we now have a forward curvature of the spine. So it's a true, just like that cheese wedge, but rather than the cheese wedge being like this, it's now like this. So from the side, we see 3 vertebrae all adjacent to each other with wedging of over 5 degrees would give you a diagnosis of Sherman's disease kyphosis. These people, when we ask them to bend forwards, we see a very strong forward curve in the spine. In terms of what you do if you think you might have scoliosis and how you go about diagnosing it, there's a few ways. Ideally, if it's a child, I think the first case is to see the GP. They should be able to point you in the appropriate direction to understanding whether it is a scoliosis, the severity of it, and what they can do about it. In clinic, if we were to see something like that, we would first start with some observations of the posture. So we'd have a look in a just standing in front of us, from the side, from behind, from the front. Have a look at the organisation of the body, and do we think that something isn't quite right. Usually you see it in the spine. If someone bends forwards, you'll see the rib cage is elevated on one side compared to the other. We can measure that with something called a scoliometer. It's basically like an inclinometer, a spirit level, that just tells you whether the rib cage is higher on one side. It indicates a rotation. We can also mark the spine and measure how far the person is shifted laterally to a central laser line. And then if we want to take it a step further, commonly this is more done in children, we can order radiological examinations, so x-rays from the back, from the side. We'll tell you the degree of the curvature and where the curvature is starting from. This is really mostly important in children as they grow. There's the potential for the curvature to rapidly worsen, which may require different means of management. In the adult, it's unlikely, as they're no longer growing, it's unlikely to really change in terms of the degree of the curvature. It's more at that point it becomes stiffness that's the predominant issue. So what type of treatments should we be considering if you have scoliosis or someone you know has scoliosis? Well, this really depends on whether they're an adult or a child, and depends on the degree of the curvature. That's probably the biggest category that should be the main category that we should be thinking about. So as general advice, those with curvatures less than 10 degrees should cope well with the right advice and some corrective exercises. They shouldn't need much in the way of manual therapy, especially with children. Children are very supple and loose and tend not to have much pain. They have the curvature through the spine, and really it's more about preventing that from worsening and managing that appropriately whilst they're growing, so that they're in the best possible position when they get older. They're not as shifted as they could have been. The spine is as upright as it can be, and then they can go through life with less pain. For the adult, they're no longer growing, so really the predominant issue is one of stiffness and pain. So we talked about the curvatures of less than 10 degrees. Should cope well with correct advice and some corrective exercises. Curvatures of 10 to 45 degrees in the child may be encouraged to wear corrective bracing. Spinecore at Sheffield Children's Hospital offer that as an option for management, where they put you into a brace, tie straps around you, and the aim is to reverse the curvature, and you would wear that for a prolonged period each day, something like 20 hours in some cases, for 18 months to 2 years, and we would see that the curvature either maintain or reduce. In the adult, in the degrees that are between 10 to 45 degrees, these are the cases that should be attempting physiotherapy type treatments. They're likely to be stiff throughout all of the spine, and they're likely to have pain, whereas the children tend not to. The adult with scoliosis is more likely to have pain, and manual therapy is directed towards mobilising the joints of all of the spine throughout, and the soft tissues that surround it is going to be really beneficial. One of the things that we have used consistently and to a lot of success is this machine behind me called the Theraflex machine. Essentially it's a tool that we use. It's a bionic hand that has 4 feet, and we walk it up and down the spine, mobilising each joint as we go. It's essentially creating a rotation at each level. The way I sometimes describe it is, imagine 2 cowboys dueling in the street, and one takes 10 paces one way and one takes 10 paces the other way, and the relative distance between the two is 20 paces. And so if we apply that to what's happening at the joint, if we rotate one joint one way and one joint the other way, the relative distance is actually double. So in other words, we don't have to put in a lot of pressure to get quite a lot of movement, double the movement for the amount of pressure we're putting in. So it's a very efficient way of mobilising the joints. And what we find is that the spine needs to be supple throughout. So when the spine stiffens, then it acts more like, for example, a road bike, where you've got no suspension and you feel every bump and jolt through the frame, through the bones. With a more supple spine, and this is what we're attempting to achieve with the Theraflex, your spine acts more like a mountain bike. It has a lot of springy suspension. You don't feel the bumps and jolts, and it distributes the forces that you put through it every day more efficiently, so you tend to feel less pain. So that's the TheraFlex. We manage a lot of scoliosis clients with that. We manage a lot of general back pain with that. Very few cases are appropriate for mobilization of the spine. Some of the hypermobile cases may fall into a category where we think mobilization isn't appropriate, but that's not the vast majority. Certainly clients that are a little bit older with some of the more degenerative conditions, arthritis, would cope well with and manage well with TheraFlex. We tend to manage a lot of them with an initial course of something like 6 sessions over 6 weeks, and then we would taper into a maintenance program if appropriate. Something like a monthly treatment works pretty well. On top of the manual therapy, just moving back to scoliosis, we also teach a series of exercises depending on the curve pattern and the age of the client, that the exercises will be specific to them. But they often focus around mechanics of breathing. If we think about the spine is in a curve pattern, whether it's here, lateral curvatures, or whether it's a forward curvature, and that's going to affect the position of the rib cage, which in turn then affects the breathing. But if we take that in reverse, if we affect the breathing, then maybe we can affect the rib cage, which will then have some influence on the spine. And what we know is, in the mechanics of breathing, is that when we have a full inhalation, we get a movement of the rib cage, which actually inserts on the spine. So by breathing correctly, we're harnessing the power of the rib cage to mobilize our spine. So it's a really powerful exercise that you can get engaged with. So we have the mechanics of breathing that we work on, and then we often teach myofascial release techniques. So this is using tools like a lacrosse ball or a foam roller or a Theracane or a tennis ball. For me, lacrosse ball and foam roller are probably the two best tools, and we can use them essentially like a physio's elbow. We can put them into an area that's got a tight, tender tissue, hold it there, release the tension, it'll feel a lot looser, and then maybe we're able to shift our body into a better position. We can start doing some corrective exercises from there. It also, just alone, by applying that pressure onto a painful tissue, you will improve the health of that tissue. You will rehydrate that tissue, relieve the tension in that tissue, so it's going to be less painful as a result. So it gives you short-term relief, but there's also some long-term benefit from doing it consistently. The next kind of category of exercises comes into corrective exercises. So these are exercises where we're attempting to establish what the curve pattern is, the degree of it, and where it occurs from. So let's say left lumbar, right thoracic, and maybe some left cervical curve pattern, maybe a rotation of the rib cage to one side, the pelvis is going the other way, maybe there's a leg length discrepancy. All these things, and what we try and do is do the opposite of them. So if the person is, let's say, shifted slightly to the left, then we would ask them to shift slightly to the right, and we'd ask them to elevate. We'd ask them to essentially hold this corrected position, brace it, hold it in that position as best you can, and then incorporate some kind of challenge into that position. So we'd hold you there, and then we'd ask you to inhale and exhale deeply, or we'd ask you to perform a row of the arm whilst holding that position, or a punch of the arm, or a rotation of the rib cage with a cable. So you're essentially holding, stabilizing the spine in the corrected position, and then adding some kind of challenge. The more functional that can be, the better. So we want it to, whenever we're training with load and we're training the body in an active way, you want it to be as relevant and as applicable to the real world as possible. So training things like a row and a punch and say a lunge in the leg is all applicable to how humans move. We walk on 2 feet, we swing our arms, we move alternating legs. So wherever possible, the exercise wants to be as functional as possible. So I think that about wraps it up. If you found this information to be useful or informative, then please give it a like and maybe share the video. If you think that it could be useful for anyone else that you know, then please forward it on to them. If you have any questions or you think that you may have scoliosis and you want to see what could possibly be done to help you, then by all means get in contact. We'd love to hear from you. Okay, take care.